We're going to talk about arrhythmias, which people tend to have a lot of questions about and a lot of, I won't say anxiety, but concern about, and they can be hard to diagnose for sure. We're going to go through a bunch of things. Now, for this one, I am going to pause for a moment on disclosures. I do have conflicts related to this talk from Janssen, J&J, and Nuvo, but I'm not going to talk about specific products from either of those companies. So that's out there. Now, three basic areas of arrhythmias that we're going to cover in this whirlwind: the irregular heartbeat, tachycardia, and bradycardia. And I'm going to try to focus on what's clinically important, although what we see for the most part are the things that are not so clinically important or not so concerning. This is that's 20 years worth of data, but old data on different things that we saw at a time that referral patterns were quite different in New England. I looked again for 2022 to 2023. We did a total of 3,300 MFM fetal echoes at Yale. There were 68 arrhythmias, 63 of which were premature atrial contractions. So the vast majority, we had 4 SVTs and 1 heart block in that time. So to cover PACs briefly, and we're seeing the PACs here using spectral Doppler. I tend to rely on Doppler a lot more than I rely on M-mode. I'm just more comfortable looking at the Doppler, and we can see that every once in a while in here there is, right there, a premature beat, a little bit of a pause, and then we see normal rhythm again. This is a frozen picture showing the same thing. So we've got E wave, A wave, E wave, A wave, and just an A wave right there. The next A wave, the timing's a little longer, compensatory pause, and then we're back to normal right there. So the question from the patient is, did my baby's heart just stop, right? Because they listen, they spend, they're seeing their physician, their midwife once a month. They spend 1 minute out of that month listening to the baby's heartbeat. That's their window besides feeling fetal movements. And if they hear an irregularity with a pause, they think their baby's heart stopped. Or they think there's something terribly wrong with their baby's heart. So part of our job is to figure it out and reassure them. How often do these irregularities represent a significant arrhythmia? How often do they relate to neonatal arrhythmias? And do they represent an increased risk of structural heart disease? Right? They think regular heartbeat, on the one hand, like everybody here, I'm sure you've seen somebody who says, how can my baby possibly have this structural heart problem? I keep going to my OB, my midwife office, they listen to the heart and they say everything sounds fine, right? On the other side, when they hear an arrhythmia, they think there's something wrong with the heart. So again, I like to look at it with spectral Doppler. I like to get either a basal view or an apical 4-chamber view, put the sample volume right there below the mitral valve at a point that I can get the aortic outflow in the same sample volume, and that allows me to see the E and the A wave below the baseline and the ventricular systole above the baseline. We did a review of all this, about 600 fetal arrhythmias. Only 43% of them actually had an arrhythmia when they came in. 55% had no arrhythmia when they came in. They all did fine. There were 10 that actually had significant arrhythmias. So if we use that criteria that Anita was talking about yesterday, 1.5% to 2% risk of something serious being there as an indication, yeah, we're in that range where we ought to take a look when these arrhythmias are heard. But we're not talking about structural problems. In those 600, I know the denominator just changed from 599 to 614 because there were another 19 patients who had arrhythmias when they came in for something else. We had only 2 structural heart disease, which is well within the confidence interval for fetal heart disease on a random basis, right? 0.5%. We had between 0 and 0.7% was our confidence interval for the likelihood of structural heart disease. And both of those had significant arrhythmias at the same time. One had SVT with an overriding aorta. One had second-degree block with corrected transposition, a known association. 2 of the kids were found to have small VSDs postnatally. Not going to worry about that. 10 significant arrhythmias, the 2 at the bottom I've just mentioned, but there was 1 VTAC in this group, 1 atrial flutter, and 2 atrial flutter, and 5 supraventricular tachycardias, all arrhythmias that we need to pay attention to when they occur. We had pediatric follow-up on about half of the kids in that study, and there were a few things that showed up postnatally, but 2 of the kids showed up on postnatal day 1, so before they went home. I'm not going to worry about one that showed up at age 4 years, and then there were these other 2. But they were all from the prenatal extrasystole group. So of the 55% who we didn't find anything on at the time of the fetal echo, we didn't have any postnatal problems. So that helps us inform what we can say to those patients after we do a good assessment of the heart. A similar study in the Netherlands looked at a larger group of patients. 24% of those resolved before the advanced scan, and there were CHD in a similar number, 1.5%. Small. This was a little bit more, I guess, but half of those were found after birth. Similar number for the tachyarrhythmias. This was based on PACs only. So they removed the ones who had no arrhythmia when they came in doing these risk factors on structural heart disease and tachyarrhythmias. If based on all comers, the risk would have been 1% risk for heart disease, structural heart disease and tachycardia, and 2%. So very similar to the numbers we got. And here's another example of basically the same thing. We've got a premature beat there, a pause. We got a normal heartbeat there, normal heartbeat there, premature beat, pause. So this is the sort of thing that we see. What's the proper management for an irregular heartbeat? Our standard is to do a fetal echocardiogram as soon as we can. Now, you all work in busy places, I bet. What does as soon as we can mean? It does not mean send the patient to triage for an NST, do daily NSTs, and make her echocardiogram appointment within 24 hours. It means as soon as we can, when we have an opening. That's when someone says, I hear an irregular heartbeat. Somebody says, I hear a slow heartbeat. Somebody says, I hear a fast heartbeat. Totally different approach. Occasional irregularity. When we have an appointment, we get her in. And we do weekly auscultation if we find an arrhythmia. Now, there are some alternatives to this. You could do a 30 to 60-minute fetal monitoring session, because what we're looking for in the fetal echocardiogram is generally any episodes of tachycardia. You could do a fetal monitoring session for 30 to 60 minutes. A quarter of these patients are below 24 weeks. Has anybody here gone to their nurses and said, I want an NST on a 22-weeker? Has anybody done that and not gotten a hairy eyeball from the nurses about it? No, it's really hard. You're trying to find a mosquito with a flashlight to get the heartbeat at that age. It's not really technically feasible to do. So that's one problem. The other problem with NSTs is someone's got to stay in the run and listen. Because if there's a 5-beat run of SVT, you're going to just see a little gap on the NST if you go in and review the tracing. Someone's got to be listening for the tachycardia. It's not enough. You don't put the patient in a room and come back an hour later. We don't do any follow-up if no arrhythmia is found, assuming it's not right close to term. We do weekly auscultation, which can be in the office. Just tell them, go to your prenatal office, just see your doctor, see your midwife, have them listen for a minute or two every week until this goes away, and then don't worry about it. Our pediatric cardiologists have a protocol when there are arrhythmias close to term that they want to get an EKG and get a Holter in the nursery. So if it's beyond about 34 weeks, and we bring people back when we find an arrhythmia now close to term, because we want to be sure there's nothing that triggers this neonatal triage protocol. But for the most part, we see them, we tell them, try to lay off caffeine if you're drinking caffeine. Now in Connecticut, it is an maybe triennial event for a patient to admit that they drink coffee during pregnancy. Very rare for people to say it, but I tell them coffee, if they're don't have a Red Bull on the way to a prenatal visit, for God's sakes, try and make things a little, you'll worry about it if you do that. So stay away from stimulants and have the heartbeat listened to once a week if we find arrhythmia. People are much more interested in tachycardias and bradycardias. There are a lot of ways to have a tachycardia in fetuses and in children and in adults. There are different mechanisms. You can have an atrial origin, represented here as an atrial flutter. You can have different types of reentrant tachycardia, where there's an accessory pathway between the ventricle and the atrium, and either the electrical signal goes antegrade into the ventricle and then retrograde to the atrium, and that sets up a cycle typically at 220 beats per minute or so. The conduction across the accessory pathway can also be antegrade, and that's the Wolff-Parkinson-White syndrome, or WPW, very similar, although it does get treated differently. So here's a fetus with a tachycardia. We can see a normal rate down below, and then we see there's a premature beat right here that triggers this run of tachycardia, 227 beats per minute. But as any of you who've done this know, very tiny movement in those vertical calipers gives you a big difference in the heart rate. So 220 to 240, anywhere in there is typical rate. Here, on the other hand, is an atrial flutter with a 2-to-1 block. So let me pause this. The atrial rate down at the bottom is going at twice the ventricular rate up at the top. And I think I've got that measured on the next slide. Yes. So we're measuring the ventricular rate. This is flipped now. The atrium's on the top and the ventricle's on the bottom. We see the ventricular rate is 440. The atrial rate is 240. But again, tiny difference in movement of the caliper is going to give you the actual rate being 2-to-1. So that's how atrial flutter looks. Here's another one. The ventricle barely looks like it's contracting. It's just moving very quickly there with the atrial flutter. And another one where you can see that the ventricular rate towards the top here is going twice the atrial rate at the bottom. I put in a lot of pictures of atrial flutter, didn't I? There's another one showing the same thing. Now, with reentrant tachycardia, these kids can get hydropic, as we know, also with atrial flutter, with any of the tachycardias. And you can learn some interesting fetal physiology to understand why that happens. We spent a lot of time yesterday talking about flow in the pulmonary veins. If we look at systemic veins, we can see this is a normal pattern on the left in a fetus that had SVT. I've put the Doppler sample volume in the inferior vena cava. The right atrium's up here. And the right atrium is down below. We see ribs here. So we've got flow here in the inferior vena cava, and here we have the flow in the inferior vena cava during the fetal tachycardia. We learned yesterday that when you see a pattern like this in the pulmonary veins, bad things happen, right, to the pulmonary vasculature. Well, when you see this in the systemic veins, bad things happen too, like eye drops, if it goes on for a long time. This is an old slide that I got from Charlie Kleinman showing a fetus during tachycardia with biphasic flow in the inferior vena cava, retrograde flow there. And here we see flow during an episode in the same fetus of sinus rhythm with a premature beat, showing forward flow. Carl Nimrod was a fetal physiologist and maternal fetal medicine physician in Canada who did some interesting studies decades ago of fetal sheep that he paced. And this is an example from his research showing baseline in the Doppler in the inferior vena cava, a fetus paced into tachycardia with that biphasic flow, reverse flow. The fetus developed hydrops. 6 hours later, the hydrops was resolving, and we can see that the fetus is compensating with an increase in flow in the inferior vena cava. So increased venous pressures, as represented by this reverse flow, probably result in the hydrops. And there is some threshold at which fetuses will develop hydrops and below which they may have occasional tachycardia but do okay. Now, I try not to tell people how to treat SVT because this is a team sport and requires a lot of people to weigh in. This is a protocol that was published in Circulation last year. I've got the QR code. And this is in the syllabus, so I'm not going to go down each pathway, but it's a set of recommendations that are probably as good as any other for treating SVT and atrial flutter. But the bottom line is, want to be sure of your diagnosis. Is it reentrant, or can your cardiologist tell whether this is antegrade conduction in the accessory pathway? Because the treatment of reentrant tachycardia versus WPW are not exactly the same. Or is it atrial flutter? You want your local cardiologist and electrophysiologist. We have, again, as I said, this is a team sport. So we will have neonatology, pediatric cardiology, pediatric electrophysiology, adult electrophysiology, maternal fetal medicine. If it comes from one of our community physicians that deliver at Yale, we have them involved. It's a whole group who need to manage these patients and be careful with the medications because anything that can stop an arrhythmia can cause one. And I'll bet that, I'm not sure if this is the case. We have to find out in the Q&A. But a lot of us who have cared for these fetuses have seen stillbirths that might have been from the medication rather than from the arrhythmia we were treating. And got to keep that in mind. These drugs interact with each other. And amiodarone can cause thyroid dysfunction, has a very, very long half-life. Often, observation is the best treatment. You got a patient who's got tachycardia, let's say 10% of the time. We admit these patients overnight before we start any treatment unless they're already hydropic. We want to establish what is the pattern. How much time is this kid in tachycardia? How much time is the fetus in sinus rhythm? Get to know it a little bit before we start throwing medications at it. Often, observation, frequent visits, 3 times a week, cool, I can do that. Home monitoring, maybe, as a way of figuring out who needs treatment. And sometimes, I stole this from one of my colleagues and friends up at Brown, Steve Carr used to say this: there is no fetal problem that I can't make a neonatal problem. And so if you've got a kid that's having tachycardia at 37 weeks, why on earth would you treat that fetus? Right? Make it a neonatal problem. They're going to be able to do an EKG, which other than the 2 places in the country, I think it's 2, maybe it's 3, that have fetal magnetocardiography and can actually do an EKG. We can't really do a fetal EKG. Now, disclosure coming up. There are companies developing ways to do fetal EKGs that are non-invasive. They are not clinically available, and they won't be for quite some time. So the reality right now is we got to use our ultrasound, and we got to use some judgment to figure out who to treat, who not to treat, and when to deliver. Now, this is a fetus that actually we saw just a couple of weeks ago. And this is ventricular tachycardia. We've got a faster ventricular rate than we have atrial rate, but the ventricular rate is only in the 200s. It's not if the ventricular rate is faster than the atrial rate, it can't be atrial flutter, right? So this was ventricular tachycardia that was successfully treated, and the baby was born, I think it was at 36 weeks we delivered this baby. Doing fine. We believe that the fetus has prolonged QT syndrome, which is associated with fetal ventricular tachycardia. But once we got the mom on some medications, we didn't see any more of the ventricular tachycardia. And last I checked, the baby still was starting to show what looked like prolonged QT on the EKG, but we had to let the medications wash out from the mom. All right. Everybody wants to know about fetal heart block and slow heart rates. When I give the talk just about bradycardia, this is the title of the talk because it's really been the case over the years. Here we have a fetus with a slow ventricular rate and a normal atrial rate. We see the atrial beats marching out here, totally unrelated to when the ventricular beats are occurring. So this is complete heart block. Half of these tend to be structural heart disease, often very complex lesions, including AV septal defects, corrected transposition in the heterotaxis, and roughly half are immunologic. This varies somewhat with the population in your catchment area. Typically, these antibodies to Rho and La or SSA and SSB, typically with normal hearts structurally. There's a lot of variation between labs on titers. I think titers are going to become really important in the future. They're going to be what tells us who we need to monitor and who we don't, but it's going to be that you've used a reference lab. The kits that most hospital labs have aren't specific enough to give you the kinds of titers you need to say no need for observation versus we got a problem here. Hydrops is frequent. Complete heart block, structural heart disease, and hydrops is bad. Complete heart block and hydrops with an immunologic cause might be treatable. We're not going to get that kid out of complete heart block. There's no treatment that does that. Now, many of us see patients with incidental findings of anti-Rho because the patient has some rheumatologic symptoms, and somebody ticks off every box on the immunology lab sheet. So they come in with an incidental finding of anti-Rho. It looks like the risk of heart block is fairly low in that group compared to the patients that have a prior child that's been affected with neonatal lupus syndrome, which can include heart block or a rash. High titers may be worse in this group of incidental findings, and you should know that a lot of these women do go on to develop true rheumatic disease later in life. The frequency of antibodies varies with the disease, but we basically check Rho and La in any patient. If the titers have been low in the recent past, the last couple of years, they're unlikely to change a lot, however, if somebody comes to you already pregnant. The risk of heart block in someone who's had a prior child with neonatal lupus is between 15 and 20%, whether it's heart block or a rash as the prior pregnancy. So those are patients who are at very high risk. The onset of heart block tends to cluster between 16 and 24 weeks. About 70% are below 24 weeks, but some happen later. Don't see it before 16 weeks. I think that's because the fetal immune system isn't responding to the antibodies yet. It hasn't developed immune competence yet. But after about 16 weeks is when it tends to happen. Can you treat these with steroids? Short answer, maybe for early heart block, not for complete heart block. You can increase the ventricular rate with beta mimetics. That doesn't treat the problem. The problem is lack of AV concordance. That sequence is important because the fetal heart is stiff. It depends on atrial systole to fill the ventricle and have adequate cardiac output. We've been using the mechanical PR interval. I'm going to skip through this because I think 5 years from now it's going to be irrelevant. This is how it's measured. We look for the E wave and A wave and measure the time interval from the onset of the A wave to the onset of systole, which corresponds electrically to the PR interval. Not exactly, but it corresponds. So that without all the diagrams, that's shown there. This is a fetus that we were following for a prior child with heart block, and this is at 20 weeks. The previous image was at 18 weeks. This is at 20 weeks. You don't need a measurement to say, wow, there's a lot of time there between the end of atrial systole and the onset of ventricular systole. And this patient went on steroids and actually reverted to a normal heart rate. So first-degree heart block, I think if you catch it at the right time, may be treatable. The question is, how do you catch the right time? Hold that thought for a moment. Hydroxychloroquine seems to reduce the risk of heart block in women at risk. So our rheumatologists in our area have pretty much everyone on hydroxychloroquine if they find them before pregnancy. And this paper from 5 years ago has the data from a study that we were involved with, along with the folks at NYU. Right now, what's going on is the so-called stop block study, which takes patients with high titers. We do the weekly echoes, but they're home monitoring 3 times a day and sending the recordings into Bettina Cuneo, who will soon be known as Saint Bettina, for doing all of this work. And because there are like 500 plus patients in this study, and she's been reviewing all of the audio recordings that have been sent in. If there's an arrhythmia, the patient's seen within 6 hours. They're offered DEX and IVIG if we find that there is an arrhythmia. This is older data with 271 patients, and 29 of those were at high risk. There actually hasn't been a heart block in this study in the last 2 years for some reason. We're not sure why. But these are some of the data that we found that we can reverse the first and second degree probably, but third degree heart block can happen within a day or two of a normal rhythm. So our old assumption that we could find these people by scanning weekly is probably wrong, and it's probably going to come down to a couple of things: having them on hydroxychloroquine, frequent monitoring, and then the latest thing, which was just published a few weeks ago in New England Journal, this review of neonatal FC receptors. These are the medications that are currently being used to prevent RH immunization in fetuses of mothers who have anti-D and other other red cell antibodies, and have been quite effective. And my prediction, and again, I'm working with Janssen, J&J, which makes one of these, although we're not using it for heart block, so I don't have a true conflict on this. I'm on the Yale COI committee, so I over-disclose. My belief is that we will use these a lot more in the future as a way of further reducing the risk of fetal heart block. So that QR code will take you to that study if you're interested. So lessons learned: first-degree heart block may be reversible with dexamethasone. Advanced block and cardiomyopathy can occur very quickly. I didn't get into it, but tricuspid regurgitation and echogenicities in the myocardium may be markers. Third-degree heart block is not reversible. I don't know if first-degree block is a necessary step. It may occur in some and not others. We need a marker. We need safe and economical prophylaxis. I think we're going to get there over the next few years. We are using hydroxychloroquine, so these neonatal FC receptor blockers may be important in the future. Finally, I learned this from one of our nurses. This is an old tracing, somebody who had fetal heart block, and we were going to do a C-section. One of our nurses said, hey, let me try to monitor her. I try to get an atrial rate. And she did it. We did it a bunch of times before she went into labor. She went into labor, was being managed by one of our community physicians who decided that this was a very ominous late deceleration. I think this is a great tracing myself. But what do you do with a late deceleration? Rupture membranes, put a clip on? Well, unfortunately, that's what he did, and got this because the clip monitors ventricular rate. Ventricular rate was 60. She had a C-section. Don't do that. You can monitor rarely. These patients basically all get delivered by cesarean, but if you're going to monitor, just do it externally. With that, thank you very much.